are going to go ahead and record this because there's several people who wanted to see it that are tied up in other meetings. And so if you have questions, interrupt, come and go to the food. It doesn't matter to me. Today is the third in a series about stroke. We covered the primary and secondary prevention of stroke. We've covered the acute treatment of ischemic stroke. And now what we're going to do is we're going to talk about intracerebral hemorrhage and subarachnoid hemorrhage. This is our update based on the 2010 and 2012 American Stroke Association guidelines. And we're talking about non-traumatic hemorrhages today. So these rules don't necessarily apply if it's associated with trauma. Our objectives today are that by the time we're done, you should know what the acute treatment of both intracerebral hemorrhage and subarachnoid hemorrhage are, according to the recommendations from the American Stroke Association. Should be able to recognize the difference in presentation of the two types of hemorrhage. And the most important thing, I think, is how do we handle these problems here at Mary Lanning. Your handouts are not going to follow slide by slide, because what I did is I actually gave you the complete handout on intracerebral hemorrhage and subarachnoid hemorrhage because they're two separate guidelines. What I've done today is to put those side by side, drawing them together so that kind of in one place we can sort of compare and see how here at Mary Lanning we can follow a protocol that actually addresses both and provides the best quality of care to the patients. And in the very back of your handouts are actually verbatim recommendations with their class level of evidence so that you actually have that specific reference right there in the handout. So what is the scope of the problem when we talk about hemorrhage? First of all, intracerebral hemorrhage is considered a medical emergency. It needs a rapid diagnosis and very attentive management because they deteriorate rapidly, and really we only have a few hours to do our best. More than 20% of people will have a significant decrease in their Glasgow Coma scale from the standpoint of being looked out in the field to the first time they're seen in the emergency room. 20% have at least 2 points. However, if you look at all of them, you'll see that many times the average is a decrease by 6 points, and our mortality rate is 75% in that first little bit. So that's why it's crucial that we know what to do with them in that initial period. Once they present to the hospital, 15% will go on and lose another 2 points. So it is a relatively significant rapid decline. And of course that risk for early neurologic deterioration really has a correlation to a very high rate of poor long-term outcomes. And really the difference we can make in these patients is in that first little bit. With regard to the subarachnoid hemorrhage, in 2003 they did a big sampling, and basically they found when they looked at discharges for subarachnoid hemorrhage, there were about 14.5 per 100,000 adults. The death rate is really pretty high, about 12 to 15% of cases before they even get to the hospital. So this 14.5 per 100,000 is probably a little bit of an underestimate as well because that mortality rate isn't taken into account. Management of subarachnoid hemorrhage is fairly frightening for most regular physicians because it has that portent of a significantly poor outcome. It really is complex, and the big thing is we're in a rapid evolution. And I kind of put some of these statistics on here just to show you how rapidly things are changing from the evidence-based approach of subarachnoid hemorrhage. The current update, which just came out last year, looked at only 42 months of literature, and then came out with 22 recommendations. 5 of them are class 1. So these are fairly significant. They're supported well. Class 1, of course, there's no question about. 2 is usually the right thing to do. 3, in special circumstances, you might not do. But 22 of them is tough to learn, to grasp. 9 changes took place just compared to the prior. So you had prior recommendations, 9 of those changed. You have 22 new ones, and of those 5 are class 1. So there's a total of the 22 class 1 recommendations altogether. Now table 3 is a reference to the original article, and I kind of left it there as kind of a big old table. The actual individual recommendations are included in the handout at the back, just the recommendation. The data from the study shows that there will continue to be frequent revision because they're just going to keep changing, and essentially this will be an area that we'll want to keep an eye on. In general, here's non-traumatic intracerebral hemorrhage, and these are kind of some of the etiologies. Hypertension is, of course, our biggest risk factor associated with hemorrhage. 11% are AV malformations. 36% are your aneurysm or subarachnoid hemorrhage. This other is a conglomerate of things. Basically, it's just kind of to show that 36% are over here in the subarachnoid place, and this is a combination of generally more of the intracerebral. When we're looking at hemorrhage, we want to take a look at what the risk factors are. And so I kind of put intracerebral hemorrhage on this side, subarachnoid here. And so obviously in our intracerebral hemorrhage, hypertension is number 1 if they're already on an anticoagulant. If they have a factor defect. Obviously, if they've had a previous history, they have a higher risk. And they are starting to look at this ApoE allele status, and we'll talk a little bit later about that. They are finding some correlation. It's not to the point that we're screening everybody, but I would watch this area pretty close because I think this will come along. For subarachnoid hemorrhage, it's more common in women. It's more common in blacks and Hispanics. Again, hypertension is a risk factor here. And here you'll find tobacco and alcohol more strongly listed. And obviously, if they've had a known aneurysm or a history of a previous subarachnoid hemorrhage, their risk is going to be higher. We try to talk about prevention because obviously our best treatment for these patients is also prevention, just as it is for acute ischemic stroke and heart attack. So high blood pressure is where our big focus is, and this is a class 1. It applies to the use of antihypertensive medication to prevent ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and any end organ injury. So this is a class 1 level of evidence across multiple evidence-based guidelines. Tobacco use and alcohol misuse should be avoided with regard to subarachnoid hemorrhage, but you also can look through your intracerebral hemorrhage and acute ischemic stroke and find comments to them, although they're not necessarily class 1. I thought this was intriguing. This is the only one where I can really find that there is a class 2B level of recommendation that in subarachnoid hemorrhage, if they eat diet rich in vegetables, it may lower the risk. Don't know quite what to do with it, except it fell out statistically. One of the things that I try to do here at Mary Lanning is to take all these different pathways or all these different guidelines and see if we can't find a common path to put our patients through as they come to us in order to increase our efficiency in our treatment of these patients. So a great number of these, we find out them and they interact with us first through EMS. So most of the guidelines have recommendations that are targeted toward pre-hospital care. The primary objective in the pre-hospital setting, kind of regardless of what type of etiology we're looking at, is to provide ventilatory support, cardiovascular support, and to get the patient transported to the closest facility prepared to care for patients with acute stroke, whether it's ischemic, hemorrhagic, or subarachnoid hemorrhage. The secondary objective is for them to obtain a focused history regarding the timing of the symptom onset, or as we prefer it, time that the patient was last known to be normal, and information about their medical history, their medication, and their drug use, so that we will have that information to help us stratify our treatment options when they get emergency department. These are level 1 recommendations from the actual guideline. And they should provide advance notice to the emergency department that they're coming with a potential stroke, so the stroke code can be activated and people can be ready to meet the patient once they hit the door and start the process. Pre-hospital recommendations are the same regardless of the etiology because the guidelines side by side, they match up pretty well. The ED evaluation is also pretty much the same regardless. We'll have a little tweak here or there. Blood pressure recommendations are a little bit different, but actually the evaluation and the workup is going to be very similar. So that's why we're trying to get everybody that comes through, regardless of whether, I mean, we don't have to wait to find out it's a hemorrhage. We don't have to wait to find out it's ischemia. They come with a neurologic deficit, start them on the pathway. In the ER, in order to facilitate, we do have an acute neurologic deficit pathway as we're trying to re-educate the culture, but it's actually the exact same pathway as acute ischemic stroke. But that way they don't have to think about it being a stroke first. They can say, oh, this is a neurologic sign. And it is working. We're kind of getting that going a little better. As you can tell by the number of code strokes that you hear paged overhead compared to 6 months ago. So how do they present? Does it give you any clues? Well, in intracerebral hemorrhage, you generally have an alteration in the level of consciousness in about 50%. About 50% will have nausea and vomiting, 40% headache. It's usually not the worst headache of their life. It's kind of a persistent headache, or it may be escalating. You know, I had a little headache yesterday, it's a whole lot worse today. Seizures in a low percentage, and almost all of them will have some kind of focal neurologic deficit, depending on where the bleed is. Contrast to that to subarachnoid hemorrhage, they generally had some premonition, something happened anywhere from 10 to 20 days before they show up. And that can be, here's the constellation. The most common is a headache, a dizziness. Sometimes they'll have orbital pain, diplopia, or visual loss. These are obviously associated with where the aneurysm went by. These are associated with the blood that was let into that subarachnoid place and irritating the membranes. But what brings them to the emergency room is, oh my gosh, this is the worst headache of my life. Anybody who says that, no matter what else is wrong with them, no matter what in the past, you have to think this. 9 times out of 10, it's not, but you have to think it. They almost always have nausea or vomiting. A lot of them will have a stiff neck. That's a good clue. People with subarachnoid hemorrhage generally don't have a stiff neck unless it's a big cerebellum. These people almost always have stiffness or pain in the neck. They're usually a little light sensitive. They can have focal neuroscience. And about 45% will present with a sudden loss of consciousness because they let a little sentinel bleed maybe a week or so ago, and then the thing popped and it just suddenly took them down. So that's fairly common. So then the next set of recommendations applies to what do we do in the ED. The actual guidelines say that the crucial resources necessary to manage patients with intracerebral hemorrhage, subarachnoid hemorrhage, and acute ischemic stroke include neurology, neuroradiology, neurosurgery, and critical care facilities, including adequately trained nurses and physicians. We don't really have quite all those things. But there is neurology, there is radiology, who read a large number of neurological studies, and we do have trained nurses and physicians in the acute treatment of stroke. We have cooperative agreements with neurosurgeons in Grand Island and in Omaha for those particular issues that require a rapid transfer. The guidelines all talk about pathways. I kind of use the word protocols. But pathways may allow for more efficient, standardized, and integrated management of critically ill patients with these neurologic conditions. So the guidelines generally recommend that we have pathways. Here at Mary Lanning, we do have pathways. Consistent across the guidelines, regardless of etiology, rapid neuroimaging with a CT or MRI is recommended. It's class 1. Here we use the non-contrast CT, and that is the case in almost all facilities, unless they're a research hospital and have some extra things going on. Then they'll do the CT plus the MR. So when we talk about imaging, this is a little older MR. Here's a newer CT. So these are the actual recommendations. I've left out the flowery language. In intracerebral hemorrhage, the non-contrast CT is the one of choice. It's what we do here. We follow the golden hour regardless of etiology, so they get their CT within 25, it's read within 45 minutes. You can do a CTA, you can do a contrast enhanced CT, you can do a CTV, looking at the names, you can do an MRA, you can do a contrast MRR, you can do an MRB, but in actual fact, in the acute hour, you need this. These things are all to stratify risk, stratify surgical options. In that first hour, those things aren't that important. So you don't want to delay your acute treatment and stabilization to go get a bunch of studies that'll take anywhere from 10 to 30 minutes. Subarachnoid hemorrhage, same thing is true. Non-contrast CT is the image of choice. The gold standard is still digital subtraction, which we don't do here. Digital subtraction angiograms are done by facilities where you have a vascular surgeon who does procedures through vessels. You can use an MRI. There's multiple modalities that may be helpful, but again, this is not necessarily what we need in that first bit. And it still holds true. If the CT is negative, they look like they've had a subarachnoid hemorrhage, they still recommend to go ahead with that. Picture time, because that's always fun. So this is an intracerebral hemorrhage. The blood is white. This is a CT. This is the bone. So here's a very large hemorrhage. And you can see that the midline shift. Here's the ventricle, the anterior horn. And here is the midline way over here. I mean, it should be right here. So we've got significant midline shift. We have significant edema showing up here as well. This is probably blood in the posterior horn of the lateral ventricle. A little harder to see with just a single slice. Yeah.
On the LP, aside from looking for red blood cells, I'm assuming?
You're looking for xanthochromia. You're not really looking for red cells.
Because I was going to say, how do you distinguish that?
Xanthochromia.
Okay.
Because what you're really looking for is the sentinel bleed, which happened before, and has already turned the CSF a little funny yellow.
What? I forgot what xanthochromia.
It's yellow. It's breakdown heme product. Heme product, yeah. Yeah, because a few red cells, you don't know whether it was traumatic or not. You can compare the first and the fourth too. Frankly, bloody. I mean, you know, like really bloody, you're going to, actually, quite frankly, I think I didn't do it very well. Got a vein. You know, so what you really want to catch is the xanthochromia. And you don't need to take a bunch out. I actually don't advocate that you take very much fluid if that's what you're doing it for. Take your CC and be done from that setting. Usually that's enough. Here's another intracerebral hemorrhage. You can see this one is right here, and here you definitely have blood in the ventricles here and here. You have midline shift, and now you have hydrocephalus. Blood's gone across and is in the opposite ventricle. This person is going to have a poor outcome. Here's a lobar hemorrhage, and we'll talk about the lobar hemorrhages a little bit more. It's more round, more discrete. It's in a lobe of the brain. And this is a subarachnoid hemorrhage. Here you can see, again, it's a CT, you can see this little white stuff kind of coming down in the gyri over here. You can see that there is some swelling on this side because the midline is over here instead of right up here. You know, these are terrible when you have trauma. I'll make it really bad. And in addition to this person is also developing a subdural at the same time. So this person isn't doing well. Here's a more typical aneurysmic bleed. It's in the cisterns, in the fissure, right here. Here's a little different look. These are also subarachnoid. This person didn't have any trauma, but his INR was 6. This guy's prognosis is much, much better than the others. And then I just thought I'd show you one of these big old aneurysms here. It bled out. It looks like it's kind of clotted itself off again. And I think this guy's developing some hydrocephalus because you can see a little bit of the temporal horn here. And this is a little bit large here. More pictures would make that easy. Pictures are always kind of fun. And this is just to remind you of the anatomy of the circle of Willis. These are where the more common sites of aneurysms are found. So, blood pressure management. That's going to be probably one of our key management issues in the emergency department. The recommendations for the 2 and for acute ischemic stroke are different. So this is where your pathway helps. Now that you've got your CT back and you know which one you're doing, you want to make sure you have the right blood pressure protocol for what you're doing. If you have acute ischemic stroke, you think they're a TPA candidate, your target is to get them below 185 over 105. If they've had acute ischemic stroke and they're not a TPA candidate, you really don't care. Even if it's 200. You don't even treat it unless it's 220. So don't get in a 2. You do some other things and then worry about it. In intracerebral hemorrhage, you want to bring it down. So it's stratified a bit. So if your systolic blood pressure is 150 to 220, they have a level of evidence that says it's probably safe to bring that down to about 140. If it's 200 and the MAP is about 150, then you're going to want to maybe go ahead and use an intravenous infusion. Blood pressures every 5 minutes, a little closer, tighter control to bring it down. And then you're looking at the 180 part here, and the difference is whether or not you think they have an elevated CP or not. Okay, increased pressure, intracerebral pressure. And if you don't think they have that, then you follow this, which you bring it down for a target of about 160 over 90. It's okay to use intermittent or continuous. Drugs of choice are listed. I mean, you can use anything. The things they mentioned are your typical labetalol. You can use cardiozyme. You can use the nitrogen side if you are high enough and want to touch it quickly. If you think they have increased pressure, then you basically want to bring it down so that you're keeping track of the cerebral perfusion pressure of about 60. This requires them to have a shunt monitor, ICP monitor. We don't do that here. That's an indication of transfer, which you'll hear about shortly. But if you're not sure whether it's ICP or not, you're perfectly fine to follow either one of these until such time that you get an ICP pressure, and then you may change and be more aggressive. For subarachnoid hemorrhage, really, the recommendation is that the blood pressure should be controlled with a titratable agent to balance the risk of a ischemic stroke happening due to vasospasm or a hypertension repeating. So you have to kind of manage that a little bit. And basically, there's that 160. So if you don't really want to remember everything, kind of remember, you get them down to 160, you're probably okay. And so if you're in the acute phase, you've got lots of things going on, and you just kind of want your rule of thumb that applies to the guideline. If they have bleeding, you can shoot for a little less than 160, systolic. If they're ischemic, don't worry. I mean, 250, you can worry. 200, you don't have to worry. And then this is a big question here at Mary Lanning with regard to hemorrhage. Who do we transfer? Do we have to transfer everybody? Well, the neurosurgeons are fine and nice, and they will take them from us, so we can send them. But they're not going to be able to do much on most. So we have to think about our patients and our families. Do we want to send them because we're uncomfortable, we just want somebody else to take care of them? Do we want to send them because the neurologist isn't here? Are they going to really have a very poor outcome, and would it be better to let them stay and have their family close and do comfort care? Those are kind of the debates. So what I've done here is kind of giving you some guidelines for those that will actually benefit from transfer, those who absolutely should be transferred, and then you should never feel bad about calling a surgeon and transferring somebody you're uncomfortable with. Okay? It's not worth laying awake at night wondering if you should have done something. So for intracerebral hemorrhage, the initial monitoring and management, really it requires an intensive care unit and somebody who has some kind of neuroscience expertise. Generally, they are not going to have emergent surgery. And I have recommendations later. And absolutely, very early craniotomy may be harmful due to the risk of recurrent bleeding. So these patients, it's a little less urgent to push them out the door. Subarachnoid ones, however, low-volume hospitals do terrible and they should ship them out. We're a low-volume hospital, we should ship them out. So we want to get in touch with the university. Dr. Thurell is the one who does most endovascular surgery for brain aneurysms. And he'll take anybody, anytime. No argument. The thing that we want to do is we want to have them stable as we can, have done what our job is, so that the transfer is as safe as we can make it. So again, the surgery is uncertain in most patients, class level 2. Here are our exceptions. These are the people that you shouldn't have to even think about. You should think about transferring. If they have a cerebellar hemorrhage and they're deteriorating. If they have a cerebellar hemorrhage and images show that the brain stem is being compressed, or they're starting to develop hydrocephalus, they need to be shipped. Okay? The initial treatment by just putting in a drain is not recommended. So that was the old thing that used to be. Oh, we can get by. We'll just stick a shunt in, they'll be fine. Not considered to be that way. What they'll do is they'll do a subtotal resection of the cerebellum. And actually, these people do pretty well. So these are the people you want to really go ahead and move out the door. If they have a lobar hemorrhage and the volume of the clot is greater than 3 ml and it's within a centimeter of the cervix, that's a surgical candidate. Now, the radiologist can calculate that volume for you. It has to do with, you know, how many centimeters, how many slices. There's calculation. It tells you how much it is. If it's less than that, they don't operate. Okay? If it's bigger than that but deep, they don't operate because the patient's just too impaired. You didn't gain anything. And the things you see on TV about taking off the skull, taking all that out, most of that is trauma-related, not necessarily a spontaneous thing. Occasionally, I think there was the congressman who did that, but that's somebody who has that happen at the big institution that's got the, what we do, surgeons and teams and stuff. So anyway, that's class 2B. Effectiveness of minimally invasive clot evacuation and all these smaller procedures and everything, basically it's considered investigation. So here's our cerebellar hemorrhage, kind of ugly, and developing hydrocephalus. This person ought to go. Here's the person. You know, if I saw this on a patient here, they're not going to be too impaired. I probably would watch that person. But once they went to this, then they move. Because the neurosurgeon's not going to do anything but watch this one. And 9 out of 10 of these will go ahead and get better on their own, go to rehab within a couple days. This person, they'll go in and take that out. But here you can see that over a couple of days it continued to bleed, and now we have midline shift, and our fourth ventricle is almost obliterated. Here's what it was. So patients who have a Glasgow coma scale less than 8, if they have any evidence of transtentorial herniation, anybody know what the biggest thing for transtentorial herniation is? Lung pupil. And those who have any intraventricular hemorrhage or hydrocephalus, or if you think they have increased ICT, then those people should go ahead and be transferred out. And this is, of course, if we do, they make a recommendation on what to do with that cerebral perfusion pressure, but you have to have a monitor in place. We don't do that here, but I put it there so you know that they are starting to pay attention, and so that would be a reason to transfer. Ventricular drainage is treatment for hydrocephalus that's reasonable in patients who have decreased level of consciousness. That's a new recommendation. And this is probably where you see me move somebody. If I think they would need a shunt or a drain, I'll just send them to Grand Island. Dr. Anderson's very good at that. He'll take them, stabilize them a day, and send them back to our rehab so they can be closer to family. Well, what do we do with them if we keep them? So now you know the difference between an intracerebral hemorrhage and a subarachnoid hemorrhage, the difference in how they present. They're all worked up the same. Blood pressure management's a little bit different. There's danger signs that will send some people out of the ED, and then we'll keep some. So then what do we do with those that we keep? Obviously, they need to go to the intensive care unit. The actual guideline says a neuroscience intensive care unit. We have a mixed intensive care unit. And it is, if you get them in there, they have a much lower mortality. It requires frequent vital sign checks, frequent neuroassessment, and continuous heart monitoring, blood pressure monitoring, and an O2 probe. So this is all put in the guidelines, all class 1 level of evidence, and this is what our routine protocols are at the hospital for our acute strokes, regardless of etiology. Blood pressure should be well controlled. After that acute period, then the goal is down to less than 140. Less than 130/80 if they're diabetic or have kidney disease. That acute period is when we're looking at the 160, or a little bit finer tuned if you can remember all that, otherwise just the protocol. Now, what do we do about those who are on anticoagulation? That's always a big question. They feel that avoidance of long-term anticoagulation as treatment for non-valvular AFib is probably recommended after the spontaneous lobar intracerebral hemorrhage because of the relatively high risk of recurrence. Lobar hemorrhages generally are due to amyloid. And so if they have amyloid in one place, they probably have it somewhere else. So they'll probably have another hemorrhage in the future. So they're probably a poor candidate. And you know there's a lot of problems. And that's because sometimes you might think about it if they're non-lobar. Because some of these people have some pretty high risk for blood clots, ischemic stroke. So this part, it doesn't tell us what to do. It tells us we can think about doing it, depending on the patient. And then, of course, they say that you should avoid heady alcohol, but there is no recommendation for statins or level of activity after a hemorrhage. Old wives' tale was they couldn't do that for a long time. Whenever they're ready, fine. This slide is busy. It has to do with other problems that we need to manage. Seizures. Well, obviously, if they have a seizure, you treat it. If their level of consciousness isn't really appropriate, then continuous EEG monitoring is indicated. That's what we do here. And now we're hooked up so that I can see it from anywhere. Waves. Don't ask me how it works, but it does. If they have a change in mental status and they did have a seizure on the EEG, they should also be treated. Everybody who has a change in mental status shouldn't be whipped onto an anticonvulsant. But if the EEG is positive, they should. Prophylactics are not considered to be useful in intracerebral hemorrhage. It is a class 3, it's a new recommendation. Some older people may decide to use it in certain situations based on experience. However, the use of prophylactic anticonvulsants may be considered in the immediate posterior period of subarachnoid hemorrhage. But they don't advocate routine long-term use unless you're actually treating a seizure disorder. Fluids. They do not recommend that we try to do a volume contraction. Basically, monitoring the volume status makes sense in subarachnoid hemorrhage. And generally speaking, when we sick them off, when they get to their ICU, they'll have a central line of some sort and measure pressures and balance their fluid based on pressure. DD prevention is important. In intracerebral hemorrhage, once they've quit bleeding, you can go ahead and go to low dose, and that's usually after 1 to 4 days. We get a couple serial ones. Okay? If you're uncomfortable with it, you can use your skids and your tits. Subarachnoid hemorrhage, they want compression stockings. So I'm a little nervy about that as well, unless you know they've been a heavy smoker and already threw 3 PEs in the past. Then I may say, you know, that clot stayed stable for 2 days, probably ought to keep them from throwing a big PE. Fever's bad. Brain doesn't like to be hot. Brain cells die when they get hot, so we really believe in controlling the fever. However, we use standard or advanced modulating systems as reasonable. So they're not saying to put them in an ice chiller, but try to keep the temperature down. Hyponatremia is a big risk. SIADH can come from hemorrhage. So you just kind of monitor your daily lights. And if you see a sodium starting to go down, start to monitor your oral fluids as they're drinking and keep a closer eye on it. And they do, in the guideline themselves, they give you recommendations on using Florida for hypertonic saline as necessary in order to keep that. Glucose, normal glycemia is recommended, class 1, regardless, hemorrhage or ischemia or subarachnoid. So what do we do about prognosis and risk assessment? There's no clock, so if I'm going too long, cut me off. For intracerebral hemorrhage, if they have a low bar one, we think they probably have amyloid, so they have a little higher risk of a re-bleed. The older ones have a higher risk. If you decide to put them back on anticoagulation, they have a higher risk. Here's our apolipoprotein E2 or 4 alleles. Those are associated with amyloid angiopathy for 2, hemorrhage for 4. Not strong enough to screen everybody, just something to start to think about and watch the literature for. And if they have a lot of Michael's beads on the MRI, then you're going to have a higher risk for hemorrhage. For subarachnoid hemorrhage, obviously if they have an unruptured aneurysm, it depends on the size of it, which vessel is involved, and whether or not it's symptomatic. If they've had a previous rupture, the risk goes up. Here's a question we get a lot of times: what do you do with those people who have familial aneurysms? Well, if they have one first-degree family member, they have a little higher risk. If they have 2, it's definitely a higher risk. And if they have a family history of a hemorrhage, it's even higher risk. Finding what frequency to screen them with MRIs is a little more difficult. It's changing over time. Generally, we do 1 because they're worried, and you usually get that paid for. And usually you can get a second one sometime in 3 to 5 years. If you have 2 without anything, it's awful hard to justify doing a whole bunch down the line. And then autosomal dominant polycystic kidney disease and type 4 Ehlers-Danlos are associated with aneurysms as well. So those are kind of your risk factors. Aneurysms themselves, these are little things that just came out that are kind of neurologists are weird. Aneurysms of the anterior circulation are more prone to rupture in people that are 55 or older. Those of the posterior communicating aneurysms rupture more frequently in men, and basilar artery ruptures are more associated with why? They don't say. So, large population studies finds all kinds of interesting facts. You get a rupture at a smaller size in people who have both hypertension and smoking than those who have either one alone. And stress does have something to do with it. A lot of people who have a subarachnoid hemorrhage from an aneurysm, preceding that they had some kind of stressful issue. Currently 7 millimeters is the size they're looking at. And there doesn't appear to be anything to do with pregnancy or the surrounding period. Those people who went in and had it taken care of, an aneurysm taken care of, their recurrent risk is pretty darn low in the first 5 years. Although if they coil an aneurysm, they'll screen that one fairly frequently in the first little bit, because sometimes the clot reorganizes and then there'll be a little opportunity for seepage. So they sometimes have to go back and put more coils in. Prognosis. For intracerebral hemorrhage, the 30-day mortality is 35 to 52%, half of them in the first 2 days. 12% were normal or minimally handicapped for 30 days. Another had a little bit of independence, so prognosis isn't really great. For subarachnoid hemorrhage, median survival is about 32%, and they have persistence of dependence between 8 and 20, and at least 20 have some cognitive issue. These people have personalities, and so, you know, they're just different people afterwards. They talk, they walk, they move around, and they're weird. They're not the same person. It's really hard on families. And they don't recognize it, so it makes them hard to take care of. Rehab is appropriate for everybody, and that's in all of the guidelines. So whether it's hemorrhage or subarachnoid hemorrhage, once they're done with the acute phase, they're all referred off to multidisciplinary rehab. It's all class 2A, whether it's ischemic, hemorrhagic, or subarachnoid hemorrhage. So what about Mary Lanning? Well, if you use our protocols, they'll be fine. And ICU for anybody you keep. Identification that those may need transfer. If you think they need their cerebral pressure monitored, if you think a shunt, if you think they might be a surgical candidate, you have more than enough evidence to transfer. If I'm not around and you're uncomfortable, you have more than enough evidence to transfer. You have people out there willing to take your transfers, so go ahead. And aggressive supportive care using all the guidelines is the most important thing that we do here. Subarachnoid hemorrhage, we take care of them in the ED, we stabilize them, identify their other medical conditions so that we can give good information to our referral neurosurgeon and transfer them. If they're past the point of any help, we always talk to the family and then for supportive care through their decline. We'll win through hemorrhage. Any questions?
If a patient is started on an anticonvulsant in the acute phase, what's the duration of time that they should be on that? Okay. Generally?
Generally speaking, a lot of them won't even go home on it if there was no indication on a repeat EEG that there was any problem. Another rule of thumb is a month. Most of your neurosurgeon will say a month. But
do you repeat an EEG prior to stopping that?
They don't. If they come to me, I do. Because it's devastating for them to think they're fine, they're doing well, and then have a big seizure. So it's not a guarantee, you know, that a normal EEG means they won't have a seizure. But if they have a normal EEG, their likelihood of being able to come off the medicine is much, much higher than if it's still abnormal and has that blood flow activity. But the neurosurgeons say, month, they're off. They say, I'll take it for a month. When it's done, you're done. And occasionally they send them 2 weeks. Any other questions? Okay. May 8th. Conclusion. How do we do cerebral death? The new guidelines for that.